Hello, my name is Jinhwan Bei, and I'll be doing a presentation on a case report on atypical presentation of Coccidiomycosis. Colleagues I worked on this project with were Dr. Timothy Ho, Dr. Mohammed Khan, and Dr. Mohammed Malekzadigan. So for background, Coccidioides species, they're a dimorphic, soil-dwelling fungi known to cause broad spectrum of disease, including severe pulmonary manifestations and also disseminated disease. It's endemic to regions in the Western Hemisphere, with Coccidioides immitis found in Central and Southern California. It's typically acquired through inhalation of spores from the soil, and majority of infections are asymptomatic in around 60% of patients, but when they do occur, they present similarly to community-acquired pneumonia, such as fever, cough, shortness of breath, and chest pain. So we have a 78-year-old male with a history of atrial fibrillation on Eliquis, hypertension, coronary artery disease, status post-stent placement, heart failure with reduced ejection fraction, who presented with acute cough and bilateral leg swelling. He was admitted several years ago for similar complaints. We had a thoracentesis done demonstrating lymphocyte predominant infusion, but there was no further workup. For the physical exam, vital signs, afebrile, a little bit hypotensive at 98/60, oxygen was 97 on room air. He had distant heart sounds on auscultation with irregular rate and rhythm. As for the respiratory findings, the left lung fields were clear, but there was reduced breath sounds in the right lower fields. In the lower extremity, there was 1+ pitting edema bilaterally. Dorsalis pedis pulses were not appreciated. There was also bilateral feet with dry skin that was noted. As for the labs, CRP was positive, troponins were negative, BNP was elevated at 633.9. Patient's TB tests with quantiferon and COVID tests were both negative. As for imaging, there was a moderate-sized right-sided pleural effusion that you can see in the picture A there. Patient also had persistent lobulated right pleural effusion measuring up to 4.4 centimeters in maximal thickness, which you can see in picture B. So following these imaging findings, we did a thoracentesis of the pleural effusion, which showed 1 liter of exudative fluid. We ran cytology, which was unremarkable. Cultures were negative. Pathology showed cocci, however, cocci spherules without malignant cells. Patient underwent VATS, pleurodesis, pleural biopsy, and bronchoscopy afterwards. We also did a serum cocci IgM and IgG, which were positive, and pleural fluid was positive for ADA. Patient was later started on diflucan. Repeat imaging showed a pleural effusion still there despite the chest tube, so we decided to put a pigtail drain to further improve the pleural effusion, which happened, and the patient was discharged home on diflucan afterwards. On follow-up, the patient did not have any recurrence of pleural effusion. So with our patient's cardiac history with symptoms of cough and bilateral leg edema, we initially thought this would be more of a heart failure exacerbation picture rather than the exudative fluids we found. It was a complete surprise when we saw that it was not transudative. Pleural effusion is a relatively common symptom of coccidiomycosis, but it's associated often with fever, dyspnea, and pleuritic pain. As of now, there have been no reports on coccidiomycosis presenting solely with pleural effusion and cough, especially in the setting of heart failure. In terms of diagnostics, IgM and IgG are done for initial detection of the disease in the serum, but culture and staining are the definitive methods for diagnosis. Once a diagnosis is made, diflucan in a dose of 400 milligrams to 1,200 milligrams daily is given for 3 months. In conclusion, while heart failure exacerbation would be one of the first differentials in our patient's initial presentation with cardiovascular history, we believe that our case report can be used as a learning point for other possible diagnoses for pleural effusion. So for the question and answer section, the first question is, do you believe that a chest tube placement may be an indication for coccidiomycosis infections with pleural effusion? So it's likely that the patient's clinical improvement was due to both proper medication regimen and pleural effusion drainage with a chest tube and pigtail drain. We believe that clinical benefits of effusion drainage in the setting of coccidiomycosis may be worth studying in the near future, especially because there have been no definitive studies on the clinical benefits of a drainage in the setting of coccidiomycosis. But it does seem like it improved in our case presentation. As for the second question, what was the differential process in this patient's setting of positive ADA and previous history of lymphocyte pleural effusion? So there have been studies showing that ADA positivity with lymphocyte pleural effusion showed very high sensitivity and high specificity for tuberculosis. But the patient did not display any other symptoms classic to TB. However, it is unique that the patient did have ADA positivity, especially with one study showing that there was no correlation between coccidiomycosis and ADA positivity. And with that, that is the end of my presentation. Thank you for listening.